I've been doing nothing but the home care of frail elderly people in Vancouver for about 25 years. And I'm convinced that we can do a better job than we're doing of that kind of care. And I'm going to tell you a little bit more about that. Somewhere in the middle of the last century, about the time I was born, and I think many of you were just getting started in life, and around the time when there was a terrific optimism as technical and scientific medicine was just getting rolling, we did something that at the time appeared to be a reasonable and sensible and wonderful thing to do. We took the end of life and death itself and removed them from the home and put them somewhere else. And so most of us have not had much experience with what I call, and what our profession calls, frailty, which is kind of coextensive with the end of life, living at home with all of its realities and all of its difficulties. That maneuver of getting frailty out of the home seemed like a good thing at the time, but gradually over the years we've begun to appreciate that it has created some problems. Frailty. Pictures are worth 1,000 words, in my opinion, and I'm just going to get you to take a look at a few former patients of mine. Right. You know what I'm talking about. You've run into people of that kind, whether you're in healthcare or whether we're talking about relatives, parents, grandparents, siblings, loved ones. These are people who are near the end of their life. There are two definitions of frailty that I want to try and acquaint you with. And I want to spend a bit of time just describing some of the things about these people as generalities that are real in their lives. Internal medicine geriatric specialists tell us that vulnerability is the essence of frailty. So a frail elderly person is vulnerable to getting into much worse trouble than a non-frail person would with any kind of difficulty, getting the flu, falling on the floor, ridiculous medication, other things that we do to people or other things that just come along and happen to them. I use this definition because it helps me to identify when somebody's frail, irremediable dependence for activities of daily living. Activities of daily living are shopping, housework, banking, food prep, transportation, medication management, dressing yourself, eating a meal, walking around, using a toilet, taking a bath, doing your grooming, all of those things that I'm pretty sure just about everybody in this room can do independently. When a person becomes frail, usually because of some problem with their thinking, often dementia, or some problem with their mobility, strokes, arthritis, very often both of those things, what happens is they become dependent on other people to get one or more of those activities of daily living done for them. Irremediable means that the reason these people are dependent on others is not for something that we can fix. It's not that they have Parkinson's, which we can treat. It's not that they have depression, which we think we can treat. It's not that somebody's put them on stupid medication, which we can stop. So they've been through comprehensive geriatric assessment, and it's clear that this dependence and all the difficulties that go with it are something that we are not going to be able to fix. So there they are. My wife, Robin, says to me, "John, don't show this slide. This is the life's a bitch, then you die slide," she says. What it shows is that with time, once a person becomes frail, their ability to do activities of daily living diminish until it's zero, at which point they're pushing up daisies. It's just a reality. That's how things work. Next slide, please. Okay, bear with me with this pseudo-arithmetical kind of stuff I'm going to show you now. This is the relationship between ability to do activities of daily living and how sick you are. This is illness along the bottom line here. And it's not linear. It's a curve. Okay, here's me today. Not much the matter health-wise. I won't go into it, but I'm still able to walk around and do my activities of daily living. This increment of illness, let's call it the flu for purposes of argument, changes my capability at activities of daily living not very much at all, you see? Here we have, let's call her Mary McCarthy. She's 88. She has mild dementia. She has kidney disease, lung disease, heart disease, liver disease, arthritis, and she's had a stroke. She has a whole bunch of health problems, and she is frail. She needs help with activities of daily living, even at best. However, something goes wrong with Mary McCarthy. That same increment of illness that would have given me the flu, maybe I gave her the flu. And there she is, much different in terms of her ability to cope. I call this the slippery slope, and what it means is this is the real natural history of frailty, because something goes wrong, there's a crisis, a person recovers a little bit, they get another real crisis, then they recover a little bit more. So the natural history of frailty is gradual deterioration punctuated by crises, but they are crises of function. So Mary McCarthy is going up and down the slippery slope all the time whenever anything goes wrong. You know, her drunk son-in-law doesn't show up to do some kind of care for her. She gets the flu. She falls and hurts herself. Somebody makes medication mistakes. Her daughter goes out of town. What have you? Each time one of those relatively insignificant health events occurs, Mary changes significantly in terms of her capability. Next slide, please. So, continually recurring crisis of function with every small change in health status means a sudden increase in dependence and need for care, and that's the reality of being frail. I get phone calls, either from people in nursing homes or from frail people's relatives. Dad can't get out of bed this morning, and we just can't cope. Normally, Dad can get out of bed, takes his walker, goes down to the dining room, gets fed breakfast, goes and sits and watches TV through the morning, has lunch, etc., and then goes to bed again because he can independently move around. We find on Sunday morning that he can't get out of bed, and we have a classic crisis in frailty. The healthcare system as we have it is wonderful. There's no question about that. It does some of the most amazing things nobody could have imagined 60 years ago. Premature babies that survive, magical operations. I wonder if many people here have had a joint replaced. Very rarely fails. Cataract surgery, nearly always successful. It's absolutely wonderful. But healthcare focuses on two things: rescue and prevention. And I'll bet many of the people in this room, and it includes me, are on medication that is designed to prevent some kind of a catastrophe. And so when we talk about prevention, we're usually talking about medication. When we talk about rescue, we're talking about dragging somebody off to a hospital in an ambulance, into an emergency room, maybe to have an operation, sometimes to get into an intensive care unit. It's the critical care rescue that our system is really good at. Unfortunately, we're no good at the kind of crisis, at dealing with the kind of crisis that frail elderly people have. That crisis of function where all of a sudden, because of something relatively trivial, they can't cope with their activities of daily living. So it's a crisis of function. And our system has no proper, reasonable, effective, sensible, reliable method of dealing with that kind of crisis in a hurry, and it needs to be dealt with in a hurry. If Dad can't get out of bed first thing in the morning, what are you going to do? You call the doctor. It's Sunday morning. You don't get the doctor on the phone, certainly not in Vancouver, and you don't get the doctor on the phone here, your doctor on the phone here either, I don't think. And so you're left with no alternative but to press the 911 panic button. In Vancouver, when you press the 911 panic button, you don't get an ambulance, you get 2 fire trucks on your lawn and blocking the street. Next thing you know, you need the cops to give you a hand to direct the traffic and keep the peace in the community. And pretty soon they need reinforcements. And the next thing you know, things get out of hand. The critical care system responds beautifully to the kind of crisis that it's good at dealing with. Heart attack, mangling injury, septic baby, somebody in labor with the baby coming out sideways, pulmonary embolism, stroke, you name it. Any of those catastrophes in relatively young people, they're very good at dealing with. However, if it's a crisis in frailty, this, of course, is where you end up. This is the VGH emergency room in Vancouver. That's the interior of the emergency room. And here we have a gentleman who couldn't get out of bed on a Sunday morning. And the reason he couldn't get out of bed, we happen to know, although the people dealing with him don't have any idea yet, is he has a little patch of pneumonia. He developed a little patch of pneumonia. And so his blood oxygen is decreased. He's feeling sick. He isn't functioning as well as he usually functions and can't get out of bed. He's probably a little bit confused. And here he is, having been transported to the Vancouver General Emergency Room, lying in the hallway, and what they've done is an x-ray, and they find out that he's got a little patch of pneumonia, and they've done blood tests, and his white blood count is elevated, and he's got a bit of a temperature, and the emergency room doctor wonders whether it's possible to send him home and put him on oral antibiotics. But when he calls the family, there's no answer. He calls the doctor, there's no answer. This is a busy emergency room doctor who's got to get on with the next catastrophe that he's going to be confronted with. And so he says, we have to admit him. We've got to bring him into the hospital. And that's what happens most of the time with a frail elderly person with a relatively minor change in their health status and a major drop in their function. They end up in the hospital. Now, there is a difference between Vancouver General and the Sechelt Hospital. The Sechelt Hospital is a lot less technical than VGH, and it's actually quite a bit safer for frail elderly people. What's worse than Vancouver General is any hospital in the United States, because they're absolutely technical, 100% technical there. So there's kind of a hierarchy of danger. Don't get me wrong, please. The hospital is wonderful. If you are having some exertional chest pain and you go and have an exercise stress test and it's positive, and you go to the cardiac catheterization lab at Vancouver General and they image your coronary arteries, and you have a 95% blockage of the left anterior descending coronary artery, colloquially known as the widowmaker, and the interventional cardiologist goes in and puts in a thing called a stent, which opens that obstruction up, and your problem is solved. This happened to me 2 years ago, and here I am. The interventional cardiologist said to me, "John, you're a lucky man," because that 95% blockage was a heart attack waiting to happen. And when that kind of thing happens to you, believe me, you're grateful. And I was grateful. There were tears in my eyes. I couldn't believe the wonderful thing that had been done for me. But when I'm 91, with moderate dementia, difficulty getting around, lung disease, kidney disease, heart disease, liver disease, too many medications, that's not the kind of intervention I need. The things that they do in the hospital are not the kind of intervention that a frail person needs. Hospitals operate on what we call policies, procedures, and clinical pathways. So if a person comes in with a stroke and they qualify in other ways, they get clot-busting medication. A person who gets a temperature on the ward gets a certain bunch of procedures done. Consultation with specialists are mandated in certain situations. They always happen. And these kinds of things are very rigid. If you're a hospital employee like a nurse or a physiotherapist, if you don't stick to the procedures, you can lose your job. If you're a doctor, you can be censured for not doing things as the evidence gathered from 40 to 60-year-old people tells us is the right thing to do. And the hospital is very good at those things. However, here's our friend who couldn't get up on Sunday morning. He's lying in the emergency room. We know he has pneumonia. He's about to be admitted to hospital. Let me tell you what often happens. Now, this is not invariable, but often this is the story of what happens to that guy. He gets admitted. They put him on antibiotics, and because he's in the hospital, they give them intravenously. He gets a blood level in no time at all. Nursing says he's confused and noisy by day 3. There's something about frailty when you move it, a frail person, when you move that person into a hospital, even if you don't do anything, they tend to get confused. Diarrhea is an invariable consequence of IV antibiotics in a hospital. This old gentleman is confused and climbs over the side rail and breaks his arm before the end of the first week in hospital. More stuff happens. Hospitals are crawling with specialists. Sechelt is safer than VGH in that regard. There's chest pain, so we get a cardiologist. He has pneumonia, so infectious disease sees him. His skin is breaking down. A wound nurse sees him. He has to have a swallowing evaluation, and he's found to be a little bit difficult swallowing, and so he's put on thickened liquids, which is not appetizing. It doesn't maintain his volume. A geriatric psychiatrist sees him and confirms that he's demented. A rheumatologist sees him and confirms that he's got arthritis. And alternate level care manager sees him and is trying to decide what to do. Each of these specialists finds what they're trained to find, and of course the frail elderly man bristles with all of the illnesses that are these people's bread and butter. Bless their hearts if you've got one of the illnesses that they could do something about for you, but they start medications. And this guy's medication leads to low blood pressure. The fact that he's not taking in enough fluid makes that worse. He's not speaking. By the end of the second week, the family declines admission to the intensive care unit because they understand that he's frail and he's demented and he's mobility impaired and he has all these other illnesses. This is somebody who could have been treated at home with oral antibiotics and got better from his pneumonia, but by the end of the 3rd week, he dies. Now, not everybody is that unlucky. You don't necessarily get out of the hospital feet first just because you've been admitted to the hospital, but it often happens that way. And it doesn't have to. When you get in the hospital, you get put on more medication. More medication means you have more trouble when you're frail, encourages admission to the hospital, and we have a bit of a vicious cycle. Okay, one of the problems here is that the frail elderly and the acute care hospital are what I refer to as the marriage made in hell. I'm no good for you, you're no good for me. Neither party escapes unharmed. It's invariable. Now, we know that frail elderly people, as in the story that I've just told you about, very often end up in trouble when they get into the hospital. It isn't politically correct to talk about the other side of that, which is that the frail elderly also harm the hospital once they get admitted. We used to use the term bed blockers, but we're not allowed to say that anymore because it feels as though we're kind of blaming the frail elderly person for being in the hospital and preventing people who can benefit from that very expensive, highly technical, very effective kind of intervention from being in the hospital. But that's the situation. And so what we have is frail elderly people who can't possibly benefit from being there, who are actually harming our effectiveness at critical care. Frailty and the hospital are one another's worst enemies. What do frail elderly people want? Number one, and this is my experience over 25 years with dealing with frail people, I don't want to be a burden on the people I love. And this generation of frail people, 80 plus, 90-year-olds, I have a patient who's 106, if you can believe that. That generation of people have that kind of wonderful attitude. Maybe they're being martyrs a little bit, I don't know, but they don't want to be a burden on the people they love and care about. They are more interested in being comfortable when you ask them, 9 times out of 10, than they are in prolonging their life with a bunch of technical things that can be done in the hospital. They want to take less medication. Why am I on so many pills, doctor? How come I have to take 12 pills a day? They don't benefit from the prevention that these pills would, according to the evidence, provide to a 40 to 60-year-old because they are different than 40 to 60-year-olds. And finally, they don't want to be in the hospital unless they really have to. If a person fractures her hip at home, nobody can fix that hip on her kitchen table. She has to go to the hospital, has to have an operation. But most of the time, when the frail elderly are in the hospital, they don't need to be. And when you talk to frail elderly people, if that person has been in the hospital in the last year, they will tell you almost without exception, no, I don't want to go to the hospital. I do not want to be in the hospital. That's what they want. I wonder if it's possible, I ask this rhetorically because I know it's possible, to offer them something else, comfort, maintaining function, and staying at home as alternate goals. It's what we do in our program in Vancouver, and it works. It really works. We have been able to prevent about 30% of trips to the emergency room, about 40% of admissions, and we have increased death at home as opposed to death in a hospital. I don't know if any of you have experienced the death of a loved one in a hospital. It's not a particularly cheerful way to go. Just by certain interventions that I want to spend a few minutes outlining for you. So this is a recipe for keeping the frail people at home. The first thing is, when we encounter patients, we have to identify whether they're frail or not. If they are irremediably dependent for activities of daily living, if they are homebound, if they're over 80, if they're medically complex, this absolutely is a frail person, and we know what the natural history is going to be, and we sit them down and we sit the family down after we've gone over all of their systems and all of their medications and all of their complaints and all of their illnesses and made sure that we're dealing with irremediable dependence. And we say, look, this is what is probably going to happen in the next 4 or 5 years. Mom has dementia. Mom has had a stroke. Mom has liver disease, heart disease, kidney disease, lung disease. She's not mobile. Her activities of daily living ability is going to diminish. So we identify who our patients are, organize a capable team. This is the Home Vive team about 10 years ago. That's me in the back row there. You don't need this many people. You don't need 8 doctors. You don't need 2 nurse practitioners. You don't need 3 nurses, physios, occupational therapists. What you need is a multidisciplinary team. That means, at minimum, a doctor and a nurse, but preferably some rehab people and a social work function of some kind. Those people have to talk to one another. And when they talk to one another and realize that they're dealing with frail elderly people at home and seeing them at home, and that they're doing something that nobody else can do, that really is helping the patients and also is helping the system to avoid having these people in the hospital, they're happy campers. Patient-centered means we do what the patient wants us to do. If the patient wants to go to the hospital, that's what we do. Most patients don't want to go to the hospital, and so we keep them out if we can, and of course we see them at home. If I could choose one characteristic of the kind of team that cares properly and effectively for frail elderly people at home, it would be that we are available 24/7. Answer the damn phone. Because crisis and frailty doesn't happen during office hours necessarily. It happens on Sunday morning, it happens at 11 o'clock at night, and we need to be available, and we need to be prepared to go and see them at home. We talk about comfort and function instead of rescue and prevention, and most frail elderly people, again I say 9 out of 10, are on board with that. They don't want to be resuscitated in the event of a cardiac arrest. They don't want to go to a hospital unless they absolutely have to. They don't want to take a bunch of preventive medication. What they're interested in is being comfortable and having their function maximized. The leader of our team in Vancouver once said to me, the way you keep frail elderly people out of the hospital is build a relationship of trust. And that relationship of trust is the fundamental relationship in helping someone if you're a healthcare professional of some kind. Now, it doesn't mean that you have to be some sort of a magically convincing person. It doesn't mean that you have to be speaking the same language, metaphorically speaking, as the frail elderly person does. What you have to do is keep your promises. Tell them, look, we're going to look after you at home. We're going to keep you out of the hospital. Answer the damn phone and show up when the person's in trouble. Simple as that. Boy, when somebody calls me at 11 o'clock at night, a new patient, the family says, Dad's short of breath and he's confused and we don't know what's going on. Can we call an ambulance? And I say, don't. I'll be there in 15 minutes. I get in the car and I go over. That buys the relationship of trust. They trust me, of all people. can't believe it sometimes. But it's a matter of just doing these simple things. Yeah. Is there another slide? Yes, there she is. This lady's daughter said to me, Dr. Sloan, if you ever show that slide again, I will sue you. Does anybody here recognize that lady? Okay, I'm done, and I thank you very much for putting up with this. Now you're going to hear from my good friend Johanna Trimble, and I guess Jane is going to introduce her. So, many thanks.